Welcome, everyone. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has mutes. You can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker can see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you if it's complete. Your feedback is important to us as we plan future programs. All right, so next I would like to introduce you to Jacquelyn Nestor. Dr. Nestor is a rheumatologist at Mass General Hospital and an instructor at Harvard Medical School. As a member of the MGH Lupus program, she is passionate about the care of patients with lupus and the crucial research required to better understand autoimmunity and improve patient care. In recognition of Lupus Awareness Month, she joins us today to give a talk on lupus. So please join me in welcoming Dr. Nestor.
All right, thanks so much for that wonderful introduction. The slides look okay on your end? Awesome, great. Well, again, thank you so much for the opportunity to speak today about one of my favorite topics, lupus. And it's nice to see some familiar names and things in the information of attendees. So thank you to all of those who are here. I first became interested in lupus as a graduate student. I was choosing a lab for which to do my PhD work. And I was really initially drawn in by the science. And it was just as soon as I met the patients, I was hooked. I was drawn in. And so it's been a passion of mine for quite a while now. And so I'm really happy to be able to share this with all of you. So let's get started. I have no disclosures. As per the initial part, none of this is not medical advice. It doesn't replace talking to your own rheumatologist. I want to start with a brief overview of our discussion for today. Lupus is a really complex disease, and I've really tried to focus on the breadth rather than the depth here today. But I'm more than happy to go deeper in any area or answer any questions at the end. Today we're going to start with a brief overview of the history of lupus, review some of the common presentations and important complications. We'll discuss some of the implications of lupus on pregnancy, and finally, we'll wrap up by reviewing some of the current and future treatments for lupus. Alrighty, so lupus, it has a long history and something that's been around for centuries. And so the first time that we see the reported use of the word lupus, it was back in the 800s, not the 1800s, the 800s. When it was first used to describe a lot of different types of rash, so it wasn't really consistently used. Lupus is Latin for the word wolf, and it wasn't really completely clear where this initial connection came from. Initially, the rashes described by the word lupus could be anywhere, but they happened predominantly on the legs, and so there was a thought that maybe that these rashes looked like a wolf bite. And so that was why the word lupus was used. But other people have suspected that the relationship to the wolf was more about the facial markings that were mimicking the common facial rash that we see in lupus. But it really wasn't until the 1800s that the butterfly rash that we classically associate with lupus was associated for the first time. And then in the 1800s, we also have our first report of lupus being more than a rash, and there being a significant systemic component as well. And although, as a disease entity, lupus wasn't officially recognized in textbooks and things until the late 1800s, We see extensive evidence of lupus centuries prior in artwork and different human remains. So this is nothing new. This lupus has been around and will be around. And so, what is the modern definition of lupus? Turns out it's a lot of different things, and it can mean different things to different people. When I meet a new patient who already has a diagnosis of lupus, I always ask, what is lupus to you, and what do your lupus flares look like? Because the answer will be very different depending on who you ask and can range from joint pain to hair loss to mouth ulcers to fatigue to brain fog and even blood clots. So we're covering a wide variety of symptoms. So it's important to find out which of these wide variety of symptoms are specific to each patient. But even with all of these different symptoms, we do see some that are more common than others. And so the things that we see most commonly are rash, joint pain, and fatigue, which is probably the hardest thing for us to treat. So it's really frustrating for us because and the patients because it's very difficult to treat. But these are the most common ones. But we know that lupus can affect almost any organ in the body, including the lungs, kidneys, heart, and so these are all very important things to consider. With especially concerns about how lupus can affect the heart, as cardiovascular disease is one of the most common causes of death in our patients. And so I mentioned rashes being the most common, one of the most common, and it's important to remember that although we often talk about rashes in lupus, there are many different types of rashes that we can see. And so the first distinction that we need to make when we're talking about rashes is that some patients have cutaneous lupus, whereas others have systemic lupus. And in cutaneous lupus, the only symptom is rash. They never go on to develop any of the systemic symptoms. Whereas in systemic lupus, as in the name, rash is just one of the many symptoms, and some patients with systemic lupus don't have rash. So it's important to separate those two things from each other. And like I said, not all rashes are created equal. One of the hallmarks of lupus is the butterfly rash across the face. But one of the most common issues we see is trying to figure out the difference between what is a rash related to lupus and rosacea. And it can be really hard to tell the difference. The biggest difference and sort of the classic teaching is that the butterfly rash in lupus spares the nasolabial folds, so those lines on the side coming from the nose down into the lips. Um, Sort of like the bottom of the butterfly here. But even then, it can be incredibly difficult to tell the two apart. And we often sometimes have to rely on our dermatology colleagues to really help us tell the difference between the two. And so now that we've reviewed some of the most common findings in lupus, it's time to look at what causes lupus. And if I'm being honest, we don't really know. We don't know exactly what causes lupus, other than that there's a breakdown of tolerance and the immune system turns on itself. And instead of attacking bad things like bacteria and viruses, it goes after its own cells. But that's something that's shared across many autoimmune disease. So a huge focus of research currently is to try and figure out what is unique about lupus and what unique things cause lupus to occur. So we suspect that one of the main reasons we haven't figured this out yet is because it's a complex issue. It has multiple causes and multiple problems. So we first suspect that there's probably many different triggers that cause lupus to occur. Likely with, the perfect combination causing lupus in patients. Among these triggers include genetics. So patients with a family history of autoimmunity have a higher risk of developing autoimmunity. We think the environment is a trigger, so things like smoking and even sun exposure. Hormones are thought to play a role. We suspect that it has to be in some part because of the predominance of lupus in women, but we really haven't figured that out yet. There's also different studies that different infections like mono, the Epstein-Barr virus could be a trigger for lupus. And then there's additionally a subset of lupus called drug-induced lupus that is triggered by specific medications and fortunately is typically a very short-lived disease. It can be very problemsome in the time that it's around, but the majority of patients with drug-induced lupus will resolve over the course of time. And so, in addition to the multiple triggers, we also suspect that there are multiple areas of the immune system that are problematic in lupus. And this could be due to the immune cells themselves. So this would be from the T cells or the B cells, which are types of immune cells, or it could be related to proteins made by the cells. So this could be antibodies, which are made by B cells, and interferon. And so all of these are thought in combination to cause lupus. And so we're going to come back to this diagram a couple times throughout the talk to talk about different types of damage and different types of medications that are targeting this area of the immune system. So the first area that I would like to focus on are the antibodies. And so these antibodies, as I said, are made by the B cells and are suspected as playing one of the hallmarks of the disease and really can help us make a diagnosis. So what goes into making diagnosis? First, it's important to recognize that it's typically not just one thing, but a combination of these factors that help us make the diagnosis. As I mentioned on the last slides, autoantibodies are a huge part of this. There are many different types of autoantibodies, and they all have different implications. The most common being the anti-nuclear antibody, which can be positive, though, in many autoimmune diseases and not just lupus. But there are also more specific antibodies, such as double-stranded DNA antibodies, Smith antibodies, RMP, and then SSA and SSB antibodies, which all can be seen as lupus as well. When we think of other diagnostic features, these things include symptoms consistent with lupus, but we also see different lab abnormalities. So things like low cell counts, like white blood cells, platelets, or red blood cells. We see low complement routinely, which can be denoted on labs as a C3 or a C4. And then in some cases, we end up needing a biopsy of tissue. Commonly, this is in the skin when we're thinking about cutaneous lupus, or especially in the kidney when we really want to understand what is causing the dysfunction. And while the tissue can be diagnostic, none of the other things on their own can be a diagnostic of lupus. And it really has to be about the combination of things. We often see patients who are very concerned that they have lupus based off of a positive ANA, but without the other collection of symptoms, it's really difficult to make a diagnosis. So it's important to just really want to emphasize that it's this collection of labs and symptoms that help us with the diagnosis. All right. So how do we know who is going to develop lupus? Do we have any clues? And it all comes back to those antibodies that I was talking about previously. And so this is actually one of my favorite scientific studies. It was done primarily in the 90s, where a group of researchers studied military members over many years, collecting their blood at various time points. And what they found is that the patients who went on to develop lupus, they actually had antibodies, so these ANA, the double-stranded DNA, and other things positive for almost 5 years in some cases, leading up to not only just the diagnosis of lupus, which you can see here on the left, but also into 5 years leading up to their actual first symptom of lupus. And this was 5 years was just the time period that they were following in this study, so it could be even longer before then that these antibodies are positive. So, although, as I said before, these antibodies on their own are not diagnostic of lupus, they are our first clue. And so we watch many patients with these antibodies very closely just to make sure we're not missing anything and to make sure we monitor for symptoms along the way. And so additionally, when we're watching for people to see who is going to develop lupus, we know that women are 10 to 1 more likely to develop lupus than men. And this is outlined in the hot pink curve here, as you can see, with the, lost my cursor. Oh, here we go. The hot pink line on the graph here. Lupus also typically affects women prior to menopause. And so this means that patients with lupus have a whole rest of lifespan for more damage to occur over time. And so prior to the development of many of our more recent medications, we would see in blue, patients would start out with those antibodies that we talked about. And so this is the time when they're not having symptoms. But eventually there meets a critical point and the patients would start having flares. And so each of these peaks represent repeat flares over time. And as over the patient's life. And this would ultimately lead to more and more damage here in red. Our goal as rheumatologists is to prevent this damage from occurring. And so what's the best way we can do that? First of all, we need to make these diagnoses earlier. And once we see that first flare, we don't want to have another one happen. And we are, very aggressive about treating lupus up front. And so with the goal of preventing these repeat flares from happening, making sure that if they do happen, they're less severe and hopefully ultimately leading to less damage over time. And I've talked a lot about damage so far, and we're definitely worried about damage everywhere. But two of the biggest organs that we worry about in lupus are the kidneys and the brain, and really the whole nervous system. Much of the concern is because the cells in these organs, so the nephrons in the kidney and the neurons in the brain, they typically can't recover from damage. And depending on who you ask, people will say time is nephrons or time is neurons. So they're very important that we prevent the damage from occurring in these organs. And so to really understand the impact of lupus on the kidney itself, it's really important to understand the role of the kidney in the healthy body. And in the most simple terms, the kidney is a filter. Blood comes into the kidney in red, and special areas of the kidney called glomeruli, which is zoomed in here, they filter the urine. They get rid of the waste, they get rid of the extra fluid, and this all then exits the kidney as urine through the bladder and eventually out the body. And this leaves behind clean blood. And so the blood is then returned through the veins in blue to the back of the body. This is a pretty impressively efficient process with all of the blood in your body being filtered every half hour. But it's a very delicate, efficient process. And disruption of this filter, as is the case in lupus nephritis, can be deadly. And so we know just that one episode of lupus nephritis can put a patient at risk for kidney failure during their lifetime. And so this is on the scale here. You can see the kidney function. So the better your kidney function is, the better is higher. And then the worse kidney function is down here. And so as people age in the healthy person here in blue, the filter gets worse. It's not perfect. It can't last forever. And so you have a slow decline in the kidney function, maybe getting down to the point of chronic kidney disease by the time you reach 100. But in the patient with lupus, here in red, we see that one episode of lupus nephritis is able to sort of bump the person down all the way very close to the chronic kidney disease. And if we are good at our jobs and we only allow one of these flares to happen, they're still going to have to account for the wear and tear that comes with everyday life. And so that patient may have kidney failure earlier. But the patient who has, continuing flares of their lupus nephritis, their kidney function continues to worsen and worsen with, for this example, the patient hitting kidney failure by age 60. So we're really aggressive about this and we really want to protect the kidneys. And one of the other things is because it's not just the kidneys that are affected. Patients with lupus nephritis have many other associated medical problems. They can have elevated blood pressure, high cholesterol, and increased cardiovascular disease, which as I mentioned in the beginning, is one of the major causes of death in our patients with lupus. And so we're super aggressive about getting those kinds of things under control. And then being super aggressive, though, we have to use treatments that have their own sets of complications. Among these being infections, which would then need to be treated, more cardiovascular disease. So we're sort of can't win in some regards. It can affect pregnancy, as some of our older medications can decrease fertility, and can be teratogenic to the developing baby. And then also long-term treatment with medications like steroids, like prednisone, can cause significant bone density loss, leading to osteoporosis and fractures, which can be debilitating. So besides the kidney, I mentioned that we also worry about the brain. I've been staring at this table honestly since my PhD, and it's probably because I find it incredibly frustrating. Neuropsychiatric lupus is a huge umbrella term that covers 19 different syndromes. So this is things from mood disorder to seizures to stroke to neuropathy. And as a researcher, as a clinician, it can be really daunting to try and find one explanation for all of these symptoms. And so it's been a real hindrance to us progressing research in this area. One of the other things that's difficult is that the incidence of neuropsychiatric lupus is very disagreed upon as a community and in the literature, and reports range from 40 to 90%. So, it's hard to treat something when we can't even agree on what it is. But it is an important thing we watch out for in all of our patients. So moving forward, now that we've sort of established the baseline regarding lupus, because lupus happens in so many women of childbearing age, I really want to talk about lupus and pregnancy. And there's a lot to talk about, so let's get started. So lupus can affect pregnancy in many different ways, from getting pregnant to staying pregnant, and can even affect the baby. Firstly, some of our medications to treat lupus, so some of the older ones like cyclophosphamide, can have a significant impact on fertility, and a woman's ability to get pregnant. During pregnancy itself, patients with lupus are at higher risk for miscarriages and different complications from pregnancy, such as preeclampsia. And we know that the patients with lupus who are at higher risk for these complications are those who have active disease, so active symptoms related to lupus. They have damage from prior disease, so they've had active disease in the past. Certain autoantibodies can put patients at higher risk. Things like the SSA and the SSB antibodies and antiphospholipid antibodies. Smoking, and then if someone has prior pregnancy complications in one pregnancy, that automatically puts them at higher risk for the next pregnancy. And additionally, as I mentioned before, lupus in the mother can affect the baby. Certain autoantibodies like the SSA and the SSB put the baby at risk for developing neonatal lupus and certain cardiac complications. So we really work closely with our maternal fetal medicine colleagues to help monitor all of our patients with lupus throughout pregnancy, and in the year after pregnancy when they're also at risk for complications. So in addition to the prior medications that I mentioned, we also have to consider what medications a patient is on during their pregnancy. Some medications like hydroxychloroquine, which we'll talk about more a little bit later, are compatible with pregnancy and even encouraged. And you can see on the left, this is the list of a sampling of the list of medications that are considered compatible with pregnancy. Whereas on the right, we have the list of medications for patients that is not compatible with pregnancy and can cause birth defects or can cause loss of the fetus. In addition, there are many concerns about some of these medications crossing into the breast milk. It's not something that is necessarily tested very often. So this is something that has to be taken into consideration in the postpartum period as well. So with all of this in mind, when is the best time for pregnancy in a patient with lupus? And this is all with a huge grain of salt because this depends on so many life factors than those listed here. So we're focusing on ideal timing, not expecting perfection. But in the perfect world, the best case scenario for a patient with lupus to get pregnant is when they're on disease compatible medications and they're in a low disease state. This is the safest time for both mom and baby for the pregnancy. It gives the mom best chance of getting pregnant, the best chance of staying pregnant, and the best chance of delivering a healthy baby. So these are really the situation that we're trying to optimize here. And so if we're going to discuss timing of pregnancy, it's also important that we discuss contraception in lupus as well, which is not one size fits all. So, one of the biggest considerations, other than efficacy of contraception, is that patients with lupus are at high risk for blood clots compared to the healthy population, and especially our patients with lupus who have antiphospholipid antibodies. We also know that smoking and estrogen can further increase the risk of clots. So it's really imperative that we take this into consideration when we're helping a patient pick the best type of contraception for them. Unfortunately, there are a lot of options available with the most efficacious, so the most effective options like tubal ligation, vasectomy, the arm implant, and IUDs. Those can be used in all patients, and they're the ones I've highlighted up here in red. But when we start going down the chart to the still effective, but not the most effective, we start seeing that we have to take disease activity and clotting risk into consideration. On the left, you can see additional methods. Sorry, on the right, you can see additional methods that can be used, but are widely considered less effective, with 10 to 25% of these patients using these methods getting pregnant by the end of a year. So switching gears, once again, I now want to shift to discussing the treatment options available for lupus, starting with some of the older medications and moving ahead to the future. And so no rheumatology talk would be complete without talking about glucocorticoids or steroids. In the short term, they're our best bet at cooling down inflammation, getting disease under control, and preventing further damage. But they have a lot of potential side effects. The things we worry about most importantly are like worsening bone density, which can cause fractures, and increased risk of infections. And patients with lupus, even without the steroids, are at very high risk for infections, and with cardiovascular disease is one of the leading causes of death. So adding on to this with steroids is something that really has to be considered every time for a patient. And so but as any patient will tell you, there are a lot of other things that come along with steroids, things like irritability, weight gain, skin thinning, hair loss, insomnia. The list goes on and on. So in the short term, the steroids are great, but in the long term, we really do have to consider other options as possible. And so the first long-term medication I want to talk to you about is hydroxychloroquine. You might have heard of this during the early days of the COVID pandemic, but long before that, it was used for lupus and other rheumatologic conditions. And even longer before that, it was used as malaria prophylaxis. So variants of hydroxychloroquine and other sort of quinine-like medications have been used for centuries. But it really came into mainstream use during World War II when it was given to soldiers on the Pacific front to prevent them from developing malaria. But during this time period, some very astute people noticed that the soldiers who had lupus and rheumatoid arthritis symptoms felt a lot better on these medications. And so then this led to sort of more further development for the use in rheumatology. And we as rheumatologists, really do love hydroxychloroquine. It's the foundation of lupus treatment. It has many, many benefits that we'll get into a little more, but just to start, it increases survival, decreases flares, decreases cardiac and kidney disease. So there's a lot of great things. It's also generally well tolerated, but it does have some side effects, one of which is particularly notable. And so the largest, the most concerning side effect is hydroxychloroquine retinopathy. And you can see on the left the sort of classic bullseye damage to the retina that can happen over time. But it's really important to remember that this isn't seen in all patients. These were patients who were on much higher doses because of they were being used to treat malaria. And they was people who were on hydroxychloroquine for decades at a time. And because of this, we have lots of guidelines to limit the daily dosing and hopefully prevent these side effects. We also have strict monitoring guidelines to make sure that uh, the patients are getting regular screening so that if we see any sign or the ophthalmologist sees any sign of retinal damage, the medication can be stopped away immediately. We've put a lot into play to really help prevent these things, but this all has to be benefit to sort of be balanced with the many different benefits that I talked about before. So if, as I'm saying, this is a balance. And so it can be helpful to look at this risk in different ways. And so on the left, we see 100 patients who are not on hydroxychloroquine. And of those 100, 73 go on to develop organ damage. So that's in the orange here. And by organ damage, we're talking about heart disease, kidney disease, and even brain disease. On the right side, we see patients who are taking hydroxychloroquine. And so on this side, only 27 patients in orange develop the organ damage, but there's a 46 patients who in dark blue avoid developing the organ damage from occurring. As we said, it's a balance. We have to talk about the risk. And so the risk is this one person down here on the right in red who's at risk of developing retinopathy. Looking at it another way, here we have survival. On the left, we have patients not on hydroxychloroquine, and of those, 17 have early deaths. And when we look at the right on patients who are taking hydroxychloroquine, we're able to reduce that to 5 patients in red with early deaths, but we're able to prevent 12 additional patients from dying. And so the risk remains the same. We have the one patient down here who is at risk of developing retinopathy. So it's definitely a balancing act, but we think we've put a lot of different things in place to help maximize the benefits while minimizing the risks to the patient. And to really bring this home, I just want to highlight some of our own work here at MGH that shows that it's not just being on or being off of hydroxychloroquine, it's the dose as well. And here we showed in a paper published last year, here on the left, that patients who were on low dose hydroxychloroquine had an increased risk of hospitalizations compared to those on the right who had high dose hydroxychloroquine and had decreased hospitalizations for lupus. So this is definitely an evolving field, and we really hope to see a guideline change in the coming years, as we feel like hydroxychloroquine dosing isn't a one-size-fits-all strategy, and that we really need to come up with patient-specific dosing to best help our patients. So I've talked about how we've repurposed old anti-malarial for lupus, and that's a recurring theme. We've done that a lot for lupus. This is done with medications like methotrexate, mycophenolate, azathioprine, and some of our more potent medications like rituximab and cyclophosphamide, just to name a few. But what about medications just for lupus? It took us a while to get to that point, and it wasn't really until 2011 with the approval of belimumab that this came to fruition. And so belimumab is a BLyS inhibitor. And over here on the right, this is that immune system chart diagram that I said we would be coming back to. And so as a BLyS inhibitor, belimumab is really targeted on the B cells and preventing their activity. And so 2011, it was approved for lupus in general. And then 2020, it was approved specifically for the use of lupus nephritis. And it's considered the first line therapy in the most recent guidelines for the treatment of lupus nephritis. It can be offered in multiple forms. It can be a weekly subcutaneous injection, or it can be a monthly infusion. Many of us really like this medication for its side effect profile compared to other medications, but it's nothing is perfect. The next medication I want to talk about is voclosporin. So this is a calcineurin inhibitor, and it works over here on the right by affecting the activity of the T cells. So the last one was B cells, this one's T cells. We have to keep our alphabet straight here. And so this is only approved for lupus nephritis. It's not approved for lupus in general. And it's also considered a first-line therapy, being added in the 2024 guidelines. It is given as a daily pill, but it does have a black box warning against increased risk of infections and cancer. And then lastly, we have anifrolumab. This is an interferon antibody, so it's uh, targeting these interferons over here on the left. It's approved for lupus in general, and this is offered as a monthly infusion. Personally, I really like this medication for skin rashes and joint pain in particular. It does a really good job with those manifestations of lupus. So what's next? I said this was going to be an evolving landscape. So we have to talk about the future and where we're going. What do we expect? What's the next big medication that's going to change the playing field? And if you ask rheumatologists, I think they would all come to the same conclusion. And that's something called CAR T therapy. And so this CAR stands for chimeric antigen receptor T cell therapy. It was initially designed to treat cancer, so things like leukemia, lymphoma, multiple myeloma. And so the process works by collecting blood from the patient to get those T cells. The T cells are then engineered in the lab to turn them into the CAR T that has a receptor that specifically targets the cancer cells. They're then grown in the millions in the lab setting before ultimately being infused back to the patient with the goal of these receptors binding to the cancer cells and killing the cancer cells. Pretty cool idea. And so it's been around for a little while for cancer. And in 2020, a group in Germany published this report that was super exciting in the field. And they changed that receptor so that instead of targeting cancer cells, it went after B cells. And so these are the cells that they're going after instead. And so coming back to our favorite graph over here, these are the cells that we're targeting. So what does this look like in an actual patient? The first studies that were out there, they reported sort of this 20-day study period with a 2-week screening period leading up to it. Once identified, the blood is collected from the patient and the CAR T cells are taken to the lab and are produced over a 10-day period. Then here in purple, the patients are admitted to the hospital where they get some conditioning therapy to get rid of your own T cells. And then the product is administered here in green over 1 day, and before being followed in the hospital for 10 days and ultimately discharged from the hospital. And I want to clarify that this is just sort of how this was done first. It's done, there's many different variations of this sort of diagram, but this is sort of the first version that was used in the initial studies and was the starting point. And so what happens once the patient receives the therapy? So on the left, we have the number of CAR T cells, the cells that were infused, and then on the right, we have the number of B cells, the cells we're trying to get rid of. And you can see over 30 days, the CAR T cells, the cells we infused, are almost completely gone from the patient. And more excitingly, we see that the patient's B cells are gone almost within 10 days, which is showing that this approach is highly effective. The question now is how long does this continue? And so one of the things, you might be asking, does this have side effects? And yes, there is. There definitely are some of the side effects, but refreshingly and almost kind of too good to be true kind of setting, it seems that the patients who are receiving CAR T cell therapy for rheumatologic cancer are doing better than the patients who are receiving CAR T for cancer. So, but we have a lot more experience the cancer field has a lot more experience and longer term follow up in these patients than the rheumatology world, where this is just really the last couple of years that things have started. And so what gets better? For this patient, the different colors, you can see the different manifestations from the lab abnormalities in yellow, green, blue, to the symptoms, so things that are in purple and orange. And you can see that everything gets better. We have a mix of really about by the day 44, this is just in one patient, both the labs and the symptoms get better. And when we look at the total score, you can see this is for 5 different patients at baseline and then at 3 months. And you can see, with the exception of one patient who has a very still low disease activity score, the rest of the patients are at 0 disease activity. And one of the most exciting things that was seen in this trial was was fatigue. And so, as I mentioned before, fatigue is one of the #1 issues for our patients. And to see a response in a clinical trial, or even just a subset of patients, was really exciting. But it's important to remember that this is not going to be a treatment for use in all of our patients. It's really been a couple of exciting years for people in rheumatology, with many trials being fast-tracked in lupus and in other autoimmune conditions as well. But like I said, this isn't going to be the treatment for every patient. It does have some significant side effects, and so we're really going to see how this evolves in the next couple of years. And it is evolving very, very quickly. And so we'll see how our different organizations, fit these new therapies into their guidelines. And so, in conclusion, we've made it to the end. Lupus is a disease that's existed for centuries. It's a collection of symptoms and lab abnormalities that can really cause deadly damage over time. We do have medications to treat it, though. Hydroxychloroquine has numerous benefits, and lupus, and with the main one that I really impart to my patients is that it can increase survival. We also have newer biologic medications that help reduce disease damage and limit the side effects that we see from steroids. And finally, therapies, including CAR T, may benefit patients with lupus in the near future. So who will say how long it will be until we get these approved? So it's really an exciting time to be in the field. I wanted to close with some resources that I find particularly helpful. Our own lupus program website here. We have the Lupus Foundation of America and Lupus Research Alliance, which have a lot of really great patient-facing information if you're interested in learning more. The Hop Step group at Duke, they have a wonderful website about lupus and pregnancy. And finally, I have a link to the ACR, the American College of Rheumatology's medication fact sheets, which are very thorough and updated very regularly with information about the different medications that we blazed by today. So thank you. It was wonderful to speak with you all today, and I'm happy to answer any questions.
Thank you, Dr. Nestor. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding inflammation. Can it trigger or cause lupus?
Yeah, inflammation is a major integral part of lupus. And so a lot of the damage that we're seeing is because of inflammation, but it can also be a trigger for disease. So we see in some of our patients with lupus, they might have a cold or something like along those lines, and the inflammation from that cold, regular, upper respiratory infection is enough to push the patient into a lupus flare. So it's definitely a possibility. Inflammation is an integral part of the disease.
Thank you. We have a question regarding one of the slides. Is neuropathy as referenced in the slide about brain condition related to kidney IgA nephropathy, sorry.
No, they're too similar. I was talking about neuropathy and nephropathy too close to each other. there is neuropathy related to the brain. We usually think about that in the terms of peripheral neuropathy. So things like numbness and tingling or burning, severe burning or almost sometimes stabbing sensations in the hands and the feet. Nephropathy is sort of more along the lines of damage to the kidney. And so there are different types of nephropathy. Um, IgA nephropathy is a very specific antibody staining process that's seen on the kidney itself. So when they take that piece of tissue, when they look at it, they see IgA antibodies. Whereas in lupus, one of the antibodies they may see is IgA, but they see a whole bunch of other ones as well. One of the sort of the ways you learn it in medical school is it's a full house. So of stains. So they're related, but separate entities.
Thank you. We have a question regarding hydrochloroquine. Is 400 milligrams of that considered a high dose?
So up until about 2017, 400 milligrams was considered the standard dose. And so for most patients, that was what everybody was on. When the guidelines came out, uh, first set in 2011 and again in 2017, the dose then became about weight. And so we see patients on anywhere from 200, 300, or 400, usually with 400 being the maximum. There's definitely some not some, there's a large proponent within the field of not going by dose and going by the hydroxychloroquine level in the blood. And that's a huge focus of research. And so that is like one of the other things that possibly needs to be changed. When I say that the hydroxychloroquine guidelines need to be changed, maybe it's not one dose fits every person at every time in their lupus. And also, should it necessarily, there's definitely people out there who would say that we shouldn't be going by dose at all. We should be going by hydroxychloroquine level in the blood. So it's a really patient-specific issue that hopefully we're going to have some progress on in the next couple of years. It's something that we actually feel very passionately about here at MGH and are working to work on.
Thank you. And there was like a follow-up question. I don't know if you are able to see that in the chat regarding the high dose, low dose of it, and if it's taken in a compound formula due to PEG allergy.
Oh, yeah. So the study that I mentioned that we did, we considered high dose to be 5 milligrams per kilogram, and low dose to be less than 5 milligrams per kilogram. It really is going by the guidelines of weight. It's more of a research-based distinction than it is like a practical distinction because in most cases, you'll be going based off of the weight and finding there's a maximum dose for the weight and also what is the maximum tolerated dose for a patient. Some people get really stomach upset when they take it, and so they take half a dose. So for each person, it can be different.
Thank you. And how can a person know when they're experiencing a flare?
Like I mentioned at the beginning, it's different for every single person. And ultimately we only want people to have one flare, right? We want them to have and that's when I mean, in a perfect world, we wouldn't have any flares. But there's the one flare and then you know, we don't have future ones. Typically, flares are very similar for a patient, and so they can become very attuned to what their symptoms are. Some patients they'll just start not feeling well, and you'll see their labs drop dramatically. Other patients, their labs won't change at all, and so it's really so important to have a relationship with these patients and your provider so that you both are not just the patient being attuned to what their flares are, but also for the provider to have an understanding. And I always, when I see patients, I always try and put that in my note of like what their flares look like, so that, if someone is admitted to the hospital and they get to look at the top of one note, the rheumatologist note, they'll see, oh, like her flares usually come with, low complement. And so maybe that will help the provider, if they're, haven't reached out to, the rheumatologist or not.
Thank you. Can inflammation come from a taxed nervous system?
That's something we don't really fully understand yet. Is it a chicken or the egg kind of thing? But stress can cause, in some way, can trigger flares for people when people are in very stressful situations. We do see patients have increase in their flares. So there's probably a connection there. We just haven't figured it out completely, whether that's a chemical disruption, or a nervous electrical impact of inflammation. But there's definitely some room for there.
Thank you. And we have a follow-up question regarding flares. Are many flares problematic?
Yeah, I mean, any flare is damage. And so, as flares happen, damage continues to increase over time. And so, in an ideal world, patients, don't have flares at all. That's what we're striving for. And, in rheumatology, we practice treat to target, and the target is no disease. That's what we aspire to. Is that a realistic goal for everybody? No, but it doesn't mean that we don't keep trying for it. And so, obviously, I'd prefer no flares, but many flares are better than huge flares in the hospital. And, there's, like I said, room for tweaking and different, finding the right dose, the right medication. We have options. We're in a much better place than we were even 15 years ago. So when we had no medications specific to lupus.
We have a question regarding how does lupus affect mental health? As an example, this person is finding that they feel less patient and more irritable.
It's hard. Um, First of all, is it the prednisone? Because prednisone, that can put a whirlwind on anybody. You take it, even patients without lupus who take it for poison ivy, or any kind of thing can tell you that it can throw you for a loop, and some people it just doesn't affect at all. But so that's number one that I think of. But lupus itself, yeah, you're dealing with a very, a heavy disease that has a lot of implications in society and things. And so, grappling with that, and something that you may have never even thought about before. Some people come from a family where, oh, my aunt has lupus, but some people don't know anybody with lupus. And so it can be very isolating. Um, the Lupus Foundation of America has a lot of great resources for patient-facing things, and finding support groups and things like that. That's it's somehow gotten harder to do some of these support groups post-COVID. You would think it would be easier, but in our experience, it hasn't been. So it's hard to, but it can be a very, heavy load. And you don't want to bear that alone, and being able to share with other patients and their experiences can be really helpful. Um,
Thank you. Is low levels of prednisone, 20 milligrams as an example, over many years, can it be damaging?
yeah, there's it's any amount of prednisone is not necessarily great. But uh, that is how lupus was treated for decades and decades. And so even though we came out with these medications 14 years ago, we'll see many patients who do still require a low level of prednisone in order to manage the symptoms. We know that doses as low as 2.5 milligrams every day for 3 months is enough to put people at higher risk for infection and higher risk for bone density loss. So, 2.5 is not that far. 2.5 is lower than is sort of a scary low number to me as a provider, but two is not that far off. But also, when people are on that kind of dose for years and years, your body actually gets like used to it. So your adrenal glands are like, well, why am I going to make cortisol when you just keep giving it to me in a pill every day? And so your body might actually become dependent on that. And so, are you really getting the prednisone? Is that prednisone just replacing what you had your body should be making, or is it like an actual extra on top of it? It's hard to tell. But it is under that 2.5 threshold that we, recently was established as sort of the bottom point.
Thank you. Are there any reports regarding hydrochloroquine patients having gas and weight gain? Do you have any suggestions on how to manage these?
Yeah, definitely stomach upset. That is something we do see sometimes. Weight gain, not necessarily as much. We do see weight gain a lot with prednisone, though. Coming back to that one as sort of being the problematic one. Stomach upset can be a problem, but you can talk to your provider about, possibly splitting up the dose, reducing the dose. There's a lot of different tips and tricks that you can discuss with your provider that still gets you that dose, but maybe makes you a little more comfortable. Um, because ideally, this is a medication you're going to take for a long time. So, we want you to feel comfortable taking it and not feel like it's an additional burden.
Thank you. We have an attendee who's sharing that they've received mixed diagnosis. One care team diagnosed them with lupus, whereas another care team said no. How can a patient manage these atypical symptoms?
It's really hard. In rheumatology, I like to say that we deal with the gray. We live in sort of this gray area, and the longer you're in rheumatology, the more you get comfortable with the gray, but it's still really hard and, to try and get used to that. I think, it depends on the specialties of the care teams, right? So, if we're talking about the primary care says it's lupus versus rheumatology, then I would probably go with the rheumatologist. If you have two rheumatologists who are going against each other, that's a separate story. Um, you know, patients who, seeing someone who is a lupus specialist can be different than seeing someone who is not a lupus specialist. Because as I said in the beginning, this is a atypical disease that looks differently for every single person. And so finding someone who has seen a lot of those variations over time and over many different patients can be really helpful when trying to figure these things out.
Yeah. We have a question on how quickly do cancer manifestations tend to come along? Specifically, if a patient has clean bone biopsy, does that suggest 1 year of feeling secure, 10 years, something different?
Um, Cancer manifestation, I guess, with certain medications, or I'm not sure. Maybe if the question's in relation to the cancer, to medications, um, I think it's different for each of these medications, and so a lot of these things were discovered in sort of the long-term surveillance studies that after the drug was approved, they followed patients out for another 5, 10 years. And so it was probably with one of those 5 or 10 year periods that they developed it and caused that warning to occur for some of these medications. But it's very, very varied. So, and we don't know if that's because We also don't know if that is that higher because people have more inflammation and that puts them at higher risk for cancers, or is it from the medication themselves? It's always that it's a very fine balance of understanding what or interpreting what to do as a provider with those warnings, and I'm sure as a patient as well.
Seems like the audience member is clarifying that lupus having a higher risk of blood cancers.
Okay. Um, Not necessarily, lupus. There are some like subsets of lupus. So things like Sjogren's. So some patients have overlapping Sjogren's syndrome, and that Sjogren's can put patients at a higher risk of lymphoma. And so those things, it's really like over time, over the course of the disease, and the longer of the inflammation you have, that can cause some of those manifestations to occur. So it's really patient dependent. There's no good answer for that one. We really try and recommend that people are up to date with sort of the standard screening um, for our diseases. What is your age appropriate screening? Getting your colonoscopy, the cervical, the pap smears, all of those things we recommend. And so but we haven't really figured out guidelines beyond that, except for Sjogren's syndrome and some of the different myositis syndromes that are out there in our rheumatology world.
So it looks like we have time for just one final question. How close are we to a cure for lupus? Is there any reason to hope?
Um, yeah, I mean, people are really excited about CAR T therapy, and to the point that it almost like people are the scare is it too good to be true? So like some of the initial patients that were in that study that I mentioned out from 2021, they presented on them at our most recent rheumatology conference, and they were doing really well. And so, is it possible that this, could be a cure? It's just too early to tell. It's something that the community and pharmaceuticals and people are just very wildly excited about, and so we're going to see, and so we're doing the trials. There's lots of the trials are happening, and so we're going to get that information soon.
Thank you so much. So it looks like that's all that we have time for today. Thank you, Dr. Nestor, for spending the hour with us. And for everyone joining today, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session will be made available, the recording, on the Blum Center website at massgeneral.org/Blum-Center. Thank you, everyone.
Thanks so much.
Take care.